So welcome everybody to a really interesting session around MedTech innovation, in particular the leverage of artificial intelligence in the cath lab all the way through from diagnostics through to education. My name is Mamas and my co-chair is Young-Hak Kim. I'd like to pass over to my co-chair now to introduce the first speaker, and we also have a great panel just joining us. So over to you, Dr. Kim.
We have several distinguished panels and the presenters. We have 6 presenters, so I will introduce in the first and the remaining 2. Let me introduce the first speaker, and Bon-Kwon Koo, my friend, and his talking today is AI in coronary imaging, mainstream or another.
Okay, so thank you, Professor Kim, for the kind introduction. Good afternoon, ladies and gentlemen. So this is my disclosure. So the question I have is whether AI in coronary imaging is mainstream or just a niche research tool. But I would boldly say that it's already a mainstream, because that when we do this kind of OCT images, previously we just collect the quantitative information or the cap thickness or small qualitative information. But now with the AI assessment, we can extract these kind of beautiful images and a lot of information, not only the quantity, but also that the quality and characteristics and also the inflammation burden. Practically, AI is everywhere in the image-based physiology, either CT-FFR and angio-FFR, IVUS-FFR, OCT-FFR, AI is everywhere. And we are now accumulating clinical evidence supporting that using AI in this angio-FFR or the image-based physiology is good in our daily practice for improved patient outcome, and some of the other clinical trial results will be presented during this session. And this kind of AI-based quantitative analysis also can be used as an ischemia prediction. So previously, we used the simulation or the computational methodologies to predict ischemia, but in this recent study by using the AI-QCA metric, actually it was better than FFRCT and better than SPECT scan in defining the coronary ischemia. And again, this AI-QCA does not having any related parameters using physiology, and in terms of prognostic value, AI-QCA ischemia was a good prognostic indicator in patients with the coronary artery stenosis. And not only in coronary imaging, this kind of AI is changing our strategy in terms of myocardial function assessment. Also, it is helpful in reconstructing the unseen microcirculation as shown in this figure. So it's not difficult to say that the AI in coronary imaging is already a mainstream and not a niche research tool. It's a very nice tool. So it may be more practical to say that whether can AI replace human intelligence in solving the complicated question like this, such as ACS risk stratification and prevention. And I'd like to talk about that issue a little bit. Because this issue is clinically relevant, because we all know that the ACS prevention is very necessary, because 3/4 of MI and 2/3 of sudden deaths present as new coronary events. However, in these patients who have more than 15 lesions in the CT scan, if this patient is destined to have an ACS, we know that it's not easy to depict or predict the one lesion that will cause the acute coronary syndrome, myocardial infarction, or sudden death. So that's the reason why it's difficult, but it's definitely necessary. But some may say that we already have very nice tools using CT scans or other intravascular imagings in terms of hemodynamics, global disease burden, plaque characteristics, and local disease burden. But we know that we still need more. But it's interesting to see that there has been several trials to show that combining all these lumen, plaque, and hemodynamic analysis can improve our prediction ability for future ACS. And EMERALD-1 trial, which was published in 2019, was designed to prove that combining all these lumen metric, plaque metric, and hemodynamic metric can increase our prediction ability to define acute coronary syndrome culprit lesion. But it was quite a long time ago. We used only 5 metric, included 215 lesions. But now when you ask your core lab or the radiologist to provide the very comprehensive information, they'll provide almost 50 metric. And when you are dealing with the 2,000 lesion 50 metric, practically it's not impossible to analyze these insights using human intelligence due to the time, cost, poor agreement issue, and complicated intervention. So for that, when we designed the EMERALD-2 trial, we tried to compare whether AI-enabled plaque and hemodynamic analysis or features were better or they worse in comparison with the conventional analysis. So I don't want to go into the detail of these metrics, but we compared the standard CT analysis and AI-enabled plaque and hemodynamic metrics. So these are very complicated study flow, but the simple comparison was that the core lab analysis by the human core lab and also the AI core lab. So we compared the performance of these 2 metrics in prediction of the future ACS coupled lesions. So we divided the total lesions into derivation and validation cohort. In derivation cohort, adding AI-QCA features improved our discrimination ability for future ACS, and it also works in the validation cohort as well. What is interesting comparison was that initially proved that the additive benefit, that the next question is AI will be better than human intelligence or human-based stenosis plus high-risk plaque characteristics, and as you can see in this figure, actually AI outperformed the human performance using lumen and plaque characteristics, and this may be the kind of cornerstone for our future analysis. Some beauty of using AI or machine learning technology is it can not only provide the probability of future ACS risk, and it can also provide the treatment target in this explainable machine learning analysis. You can see that this kind of increased probability is mainly due to the delta FFRCT in this case, and you can see all these degree of contribution of metrics so that you can decide your treatment strategy according to the parameters that can influence of this lesion according to this probability. Another very important issue is that the time to event probability. So we can generate using these models the time-dependent event probability so that you can select either using revascularization or the medical treatment according to the time. So when these strategies can be applicable in our daily practice, when someone is doing intravascular imaging or a CT scan or whatever they do, we can use a AI-based analysis, and we can also use the AI-based time-dependent risk modeling and selecting the risk itself and time-dependent risk probability. And if that risk is very high in a short-term period, we can do an explainable machine learning analysis to select the personalized decision-making. In this case, PCI may be the right choice. And if the patient can follow these very low risk and the risk does not increase in the long time, we can simply do the medical treatment and follow up non-invasive tests. So in this question again, AI in coronary imaging, is it a mainstream? I would definitely say it's already. However, not yet, because we need to solve some issues on data quality, standardization, and clinical validation evidence, and interpretability, and transparency. But we know that the AI will be the future, so that I'd like to wrap up my talk with quoting this very famous quote. Thank you very much for your kind attention.
Thank you very much. I think that quote that you showed is very relevant, and I completely agree with it. The next speaker will be Dr. Higami, discussing guiding catheter stimulation.
Thank you, Chairperson, and thank you for having a good opportunity to present my project, AI guiding catheter simulation. I'm Hirohiko Higami from Japan. This is my COI. And guiding catheter has 3 roles. One is, of course, the backup support. System support is very important And of course, backup support is particularly important for this complex case, but and sometimes it is difficult to choose the appropriate guiding catheter size and shape because we can't see the out and we cannot confirm the out, ascending out size. And next role is coaxiality, particularly the region is very close to the orifice of the coronary arteries. Coaxiality is very important, and particularly in like this case, this is ostial coronary RCA CTO case. And coaxiality is very important to having a good approach from the antegrade. And sometimes rotablade advance and manipulation in the guiding catheter coaxiality is very important. And the third role is the engagement, particularly for the anomalous coronary artery. And for example, in this case, many operators failed to engage to this anomalous RCA for 4 times. But after I performed the VR, virtual reality guided simulation, the operator succeeded to engage to this RC, and this patient has the CTO in the segment 2. So VR simulation is very effective, and I already reported the case report. But the virtual reality simulation is sometimes complicated. And it is difficult to use for all the clinical PCI operators. So I improved the guiding catheter simulation from virtual reality to AI. And I made this AI-guided guiding catheter simulation system. And this system will make PCI simple. This system can analyze the guiding catheter size and shape, and we can choose at first we can choose the best size. If we want to use the AL for RCA, the AL, for example, AL 1.0 is the best size for this patient, and if we want to the backup type for LCA, this size is the best. This AI simulation system suggested that. And we can also comprehend the coaxiality for the coronary artery. If I use the AL for this patient, the coaxiality is like this, and we can confirm the visualization, and the AI can calculate the how much degree to the coaxiality. So this system can suggest what size of the what size is most appropriate, and this application suggests the best shape and whether we have to use the side hole or not. And final portion. This simulation system detects the coronary anomaly. This is 3 types of the LCA anomaly, and this is 3 types of the RCA anomaly. And this system can detect each type of the anomaly. And I performed the VR simulation for these coronary anomaly. So I have a knowledge to how to overcome these anomalous coronary artery. So this AI can suggest how to overcome in each anomalous coronary patterns. And this system can detect the coronary rotation. At first, this AI can detect each cusps and detect each commissures. So this system can calculate how degree from the commissure to orifice of the coronary artery. So this system can detect the coronary rotation, and this system can also detect the ST junction. So if the coronary artery originated from above the ST junction and the rotation is very RCA, or vice versa, RCA rotation is very originated from anterior, this we can detect the anomalous type of RCA. And this is the RCA originated from LCC case. This is, I think this is the most difficult case to engage the guiding catheter, because the 2D shaped guiding catheter is difficult to engage for this type of anomalous coronary artery. So this AI suggests like this 3D shaped curve. So this system can suggest and detect the anomalous type of coronary artery and suggest how to engage for this anomalous coronary artery. And in the application, all we have to do is just click the analyze button, and after full auto simulation, we can confirm like this visualization. And we can change the guiding catheter shape from the backup type to JL type, for example. And we can prepare the guiding catheter previously PCI. So we can use even the minor shape guiding catheter, and we can choose the large size or small size for this in each patient. And in addition, previous CT has a value because the anatomical information of the valsalva and ascending aorta and coronary artery is almost the same within a few years. So we can use the previous cardiac CT to simulate guiding catheter. So I think the guiding catheter simulation makes PCI simple and makes a new PCI world. Thank you very much.
Thank you for a very interesting talk. I now introduce my co-chair, Dr. Young-Hak Kim from Asan Medical Center, who will focus around the role of AI for revolutionary medical auxiliary diagnoses.
Thank you for introduction. And so my topic today is AI for medicine and the cardiovascular disease diagnosis and treatment. And this is my disclosure. And the last year, HA provided a statement about the potential possibility of AI, and still they suggested that it has a limitation to be overcome. And I have running and medical AI labs and the company with the AI expert. And my presentation today is mostly done in the lab. And most of them are very technical, but I think understanding the concept is enough for clinicians like you and me. And the first step to create a medical AI is to build up data sets. And we are focusing on the electronic medical record from the large hospital. So based on the AMC large registry from the electronic medical records, and we have some interesting clinical researches, as you see here. And the early LDL reduction was associated with lower risk of MACE. And with the same data set, and we proved lipoprotein A was associated with high risk of MACE, in particularly type 2 diabetes. And this is application area with the large data set created from electronic medical record. Prediction is one of the purpose of medical AI, and we leverage the multimodal clinical data, including EHR, imaging, genomics, and signals, and it supports personalized care and data-driven clinical decisions. And as you see in the on-chest X-ray, our model creates the border of the cardiac borders and then measure the distance automatically of each point of a cardiac border. And this model is used to classify valvular heart disease, and the outcomes is also associated with the medical clinical outcomes of the patient. And the eGFR can also be predicted with the heart failure patient, because as you know, and renal function and the cardiac function is very closely associated for heart failure patient. And based on the different features at each point, and we can predict the eGFR for heart failure at each point. And the directed dose was also adjusted with the AI model for heart failure patient. And it is similarly, and based on the different features, including body weight and the urine output, and directed dose can be adjusted automatically by AI model. And this is interesting technique to transfer first model to another one. So firstly, and in large data set, including my center, first model was created to predict MACE for cardiac patient. And then when it transferred it to small population of a cohort, such as a small size of the hospital, and the model performance was improved a lot from the blue line to red line, as you see. And now, currently, we are focusing to develop a medical-specific large language model. And it is domain-specific foundation model, and we have a hypothesis that medical-specific large language model can have a better performance than general LLM as you use ChatGPT. So PAM-M is a Google-created medical AI model, and they suppose that many possibilities can be made with this model. And the lag is a technique to work as a knowledge library. So with this lag techniques, and we can improve the performance of a medical-specific large language model. So we already proved that medical-specific large language model had a better performance than the general LLM and in papers. And the DPO is another user technique to improve the performance of large language model. As you see, general large language model can create multiple responses at one question, and then medical expert provide a ranking of multiple questions. So with this data set and the final medical specific LLM improve the performance and increase the accuracy. So this is interesting, and the study, and when the patient is matched, we developed the AI model with a database of clinical trial, GOB, and some medical center and clinical trials. When a rare disease or terminal patient come to your clinic, and you can match the patient into appropriate clinical trials with this model. And the patient clinical outcomes also can be predicted with the LLM clustered patient subgroups. It's like a machine categorized disease category. So with this data sets and with this lag library, and you can improve the clinical prediction of patient and the outcomes of patient. So patient data security and the safety is also very important in AI area. We published this paper in the New England Journal of AI in this year, so I'm very honored to be a few person who published the NEJM and the NEJM AI. And we won in the society that the LLM can rig and the patient privacy or doctor privacy, as you see. When you put the chaotic questions in the prompt, as you see here, and unintentionally, LLM can expose the important privacy of the patient and the doctor. So we are providing two solutions to be developed. The first one is de-identification. De-identification is a very complex technique with the current techniques. And we proposed the AI-suggested automatic de-identification of the population. So we can hide the privacy. However, the characteristics of the population can be preserved. So with the data set, we can create a model. The second one is a synthetic data. Synthetic data is not real one, it's fake. However, and it still possesses the patient characteristic and the population characteristics, so synthetic data can be used as a development model training. Another one, the final one, the smart health service, is going to be used for administration. So echocardiography report can be generated with echo findings, and this model is created by large language model. So this is the result. And the next, the inpatient patient outcome can be generated automatically based on the hospital course and the doctor's text and the reports. And also in the busy emergency room, as you see here, and this model can predict the hospital occupancy and the ward occupancy, so it can be used to administrators. this is my conclusion. AI in healthcare is being applied in many, many areas, as you see here. And we hope we can find unresolved unmet needs in the hospital and Assam Medical Center, and find clues to solutions through researches using AI in the labs, and commercialize them in the company for medical healthcare. Thank you for your attention. The next speaker is going to be Seung Ryu, and the title is Simulation and Interventional Cardiology Education and Training.
Thank you very much for that kind introduction. After hearing all these phenomenal talks about how AI will probably eventually replace most of us, I thought we would turn around and look at how technology is still fighting to keep us relevant in the field. So I think the first fundamental question you always have to ask about something is why. You know, there's a very clear moral reason to simulate, and the Mayo brothers, even in the 1930s, recognized this, and they said at that point that there was no excuse today for the surgeon to learn on the patient, and that probably in the not far distant future we will crawl out of our old methods of education as a snake sheds its skin and reorganize a new plan. We are almost a century ahead from this, and I would argue that at this point we are probably still in exactly the same place. In Asia, especially when you ask people, do we use simulation, most people say that the patients are our simulators because there are so many of them. But you know, there are lots of things that favor the role of simulation training in interventional cardiology. There's continuous development and evolution of more new complex interventions. There's inconsistent exposure with the apprenticeship model. Work hour restrictions are eating into things. Procedural numbers are falling. Some procedures have steep learning curves, and we have a lot of potential for life-threatening complications. Especially, I think, in Korea, in the setting of your strike and all these other things that happen to our workforce, there's a need to have the ability to control the training schedule around the work schedule and to move away from quantitative to qualitative thresholds. Not all simulation is created equal. The best simulation is individualized to a person. It's performance benchmarked to specific levels. There's metric-based feedback. But it's very important to understand that you use simulation specifically to train specific competencies. It cannot replace the entire procedure. It is also very important to recognize that poorly conducted simulation can actually enforce incorrect behavior. Knowing all of this, the US and European graduate medical education and bodies, including ACC, COCAT, ACGME, EAPCI, American Board of Internal Medicine, have all, in their training documents, insisted that we provide fellows with access to training using simulation to support fellow education and patient safety. Despite these strong statements, nowhere in any of these documents does it tell you exactly how do you go about using simulation to train people. We are all familiar with these modern, quote-unquote, endovascular simulators at this point. They have been around for the better part of a decade and a half, or 15 years. Currently, the leaders are the Mentis simulator that you see in the middle up here. And then we also have surgical sciences, which used to be Symbionics and I think that's actually on your exhibition floor. The Japanese, and I love building wet simulators that are actual models that you work on. And you know, there's a lot to be had here. And in the more advanced capabilities, I think the more exciting things that are happening now, the Mentis G7 Plus has the ability for you to put 2 wires into a single port so that you can start to learn bifurcation simulation steps such as provisional stenting, TAP, culotte, reverse culotte, and DK crush, etc. This is an example of having both wires in at the same time, and I helped work with Mentis for 5 years developing these modules here. You can see the 2 wires are moving independently. And then the other exciting thing about, I think, simulation in an environment is that it can provide a visualization of work that is above and beyond what we can normally see under normal conditions. And here we were putting in an overlay to show you exactly what happens when you rotate your catheter, which direction does this result in the rotation of that catheter. It is unavoidable to ask the question, where's the role of simulation in industry? the involvement of industry is unavoidable because of the cost of module development, system support, and trainer support. There are many simulation modules that are only exclusively available via industry. You cannot go and buy these. You can only get to them at a national course, etc., like this. But we have to ask the questions when we have ceded so much of training to industry. Should there be formal standards for module development? Should there be better access to modules instead of having to go through industry to get there? This is an example of evidence for benefit. When people say, is there actually any evidence that supports this? This is a trial that we did at the University of Arizona. What we were trying to do was we used a specific visual overlay to help people learn coronary angiographic views in a faster fashion. We took 105 medical students, residents, and fellows. We randomized them in a stratified fashion. All the participants were pre-tested to categorize 30 clinical angiographic views. What view is this? Then all participants watched the standard way of learning, which was Morton Kern's lecture on angiographic views. And then we took half the participants and we spent 15 to 20 minutes manipulating a Mentis virtual C-arm with overlaid virtual anatomy with supervision versus the standard control, and then we retested them again. And what you can see here is that for the medical students, there was clearly improvement in both groups, but there was a slightly higher improvement, statistically significant, in the simulation subgroup. In the residents, you actually saw the greatest benefit. In 15 to 20 minutes, we took residents who had no real coronary angiographic training, and we brought them to the level of about a first-year fellow. Fellows already knew the views, so we didn't see much difference with them. And this proves that there is a specific methodology that helps them get there. We then recently, last year, performed a SKY survey on simulation, and we sent out 420 surveys, and we got 420 responses. And we asked the question, how many % of you have been exposed to simulation? And the answer was about 70%. And we had both United States and outside United States responses. And then when we asked the question, how many of you feel like you have insufficient simulation training? And across the board, it is still 70%. So most people want more simulation training. What are the barriers to your simulation training? Lack of access to equipment and technology is number one. Number two, lack of simulation facilitators. Number three, lack of funding. Then lack of curriculum, lack of time. And when we asked them who should lead simulation training after fellowship, everyone agreed that it should be the national societies as well as simulation centers. And then industry, which is currently in the lead, was somewhere in the middle. And then everybody thought that hospitals and examining bodies should stay away from this. When we asked them, what do you think simulation is most useful for? Most people felt new procedures, basic technical training and procedural planning, then advanced training, then complications training. And then board certification, etc., was lower on the list. When we asked, what was your exposure by simulator type? Most people nowadays are exposed to digital procedural simulators, like the ones that you saw, and then dry simulator models next, and then it goes down all the way to virtual augmented reality's lowest. The highest site of simulation training were industry organized training, followed by national cardiology meetings. And then the format is usually small group and very few self-directed training sites. So now I want to bring you back to 2014, where SKY actually published the current state of medical simulation and interventional cardiology. At that point, they did recognize that uptake was low. There was skepticism on efficacy, fidelity, and improvement in performance. There's a lack of expertise and familiarity, lack of proven curriculum, and that it's cost prohibitive. And I would say in the 11 years, still not much has changed. So to conclude, simulation facilitates patient safety and provides safe, standardized environment, especially for new learners, new procedures, and complication response. The cost of both simulators and training programs remain prohibitive. Significant underutilization persists. Future efforts should really focus on understanding which skills are best suited and how is that training best delivered. And there needs to be standardized international programs with consistency in module development as well as universal timely access. So the challenge to our community is this: how do we build these ecosystems? Thank you.
Thank you very much, Dr. Lee.
Yeah, so the final presentation, Dr. Yongcheol Kim, the usefulness of AI-QCA, lessons from the FLASH trial, and then we'll have the previous speaker up with the correct presentation. So can we put the FLASH trial talk up, please? Hopefully this is the correct one.
Yeah, thank you, Mamas. Today I'd like to talk about the AI-QCA assisted PCI. This is my disclosure. There are strong evidence of the image-guided PCI, but reality is that the clinical benefit of intravascular imaging are less well established in the less complex coronary artery disease, and its global use is likely to remain limited because of the various issues. Therefore, in the real-world practice, the angiography-guided PCI has become the de facto strategy due to the variety of the circumstances. So theoretically, angiography-guided PCI refers to QCA-guided PCI. So GUIDE DS trial demonstrated the QCA and the IVUS guidance during the PCI showed the similar rate of 1-year target lesion failure. However, the complex protocol of QCA-guided PCI in the guided DS is difficult to apply in the routine daily practice. Furthermore, in the real-world practice, angiography-guided PCI seems to be the eyeball-guided or visual estimated guided or experience-based PCI. It should not have happened, but sometimes the eyeball-guided PCI by early career might lead to this kind of disaster, as you can see. If the AI could provide more accurate QCA data of the distal lumen diameter of 2.07, operator would not have selected 2.75 stent diameter. Therefore, we conducted and designed the FLASH trial regarding the AI QCA-assisted versus OCT-guided PCI, which the randomized non-inferiority trial. So AI-QCA is developed by Medipixel, is the domestic Korean company, and offer the real-time automated analysis of angiography without any requiring additional time and effort. So among the 400 patients with coronary artery disease undergoing the stenting, we randomly assigned the AI-QCA-assisted PCI group and the OCT-guided PCI group. Primary efficacy endpoint was minimal stent area by final OCT among the whole 400 patients. Why we selected MSA as efficacy endpoint was that the MSA is the most directly related post-stenting surrogate marker to patient prognosis after stenting. So we excluded complex lesions such as left main disease and the CTO region and the graft lesion and the bifurcation lesion requiring 2 stenting technique. So 13 hospitals in South Korea were participated in the FLASH trial, and the PI was Professor Jung Min-an in the Asan Medical Center. So we suggested the AI-QCA-assisted PCI protocol in the stent size, and the post-stenting final NC balloon size was selected in up to 20% larger than the distal reference diameter. And the stent length was chosen based on the lesion length provided by AI-QCA. So in the FLASH trial, another important point is the safety of the AI-QCA-assisted PCI. Therefore, while generally discouraged, but in the AI-QCA group, after final OCT evaluation, additional procedures were permitted to correct significant suboptimal stent result detected by OCT. So regarding the procedural characteristics, the mean stent diameter and the maximal non-compliance balloon size was significantly bigger in the AI-QCA compared with the OCT groups. This slide we are looking at is a primary endpoint. Is the MSA was 6.3 square millimeter in the AI-QCA group and 6.2 square millimeter in the OCT group, with achievement of non-inferiority of AI-QCA compared with the OCT. And regarding the OCT-defined endpoint, there is no significant difference in the stent underexpansion, dissection, and untreated reference segment disease. However, malposition occurs is significantly frequent in the AI-QCA group. However, the mean MSA in the malposed segment was 8.4 square millimeter, which was acceptable, and the no malposed segment has a MSA less than 5 square millimeters. And there is no significant difference in both groups regarding the post-interventional QCA. And regarding the procedural complication, there is no significant difference. However, in the QCA group, the 16 additional procedure was done in the 60% of patients to the correct suboptimal result. 6 months clinical outcome were similar in both groups. So in the FLASH trial, AI-QCA assisted PCI achieved the non-inferiority minimal stent area compared to the OCT-guided PCI in patients with less complex coronary artery disease. So you can see the further detail in the design paper and the main paper of the FLASH trial. Now I'd like to show how I perform the AI-QCA assisted PCI in my daily practice. Is a 57-year-old gentleman complained effort angina, and the angiography showed the severe stenosis in the distal RCA and intermediated to the severe stenosis in the previously drug-coated balloon treatment size of the mid-RAD. So AI-QCA provided is real-time data of the lesion length and both reference diameter. So with these references, I performed the AI-QCA assisted PCI with 2.5 millimeter drug-coated balloon after POBA with 2.5 millimeter scoring balloon. And the final final angiography showed a good distal flow without residual stenosis. In the mid-RAD region, the AI-QCA showed the 52% of diameter stenosis, which means that we need a functional assessment. So RFR value showed the 0.83 and the FFR value showed the 0.66. So with the real-time QCA data, I performed the AI-QCA assisted stenting with 2.5 by 28 millimeters. So I was very happy with the successful AI-QCA assisted PCI for the multivessel disease. Now we are using the AI-QCA for our fellow to promote or understanding PCI during the angiography guidance or even the intravascular imaging guidance. Now AI-QCA assisted PCI is just the beginning, but I can say that the FLASH trial was the first study to suggest the possibility that AI can help physician in real time in the treatment area rather than predicting the prognosis or determine the treatment. Thank you for your attention.
So if we can invite the previous speaker, Dr. Ryu, and hopefully we have the correct presentation this time.
I sincerely apologize for any inconveniences that may have caused. Yes, so the topic that I'm presenting today is lessons learned from development of technology-based behavior intervention program for multi-ethnic groups. And despite recent advancement in computer and mobile technologies, technology-based interventions for multi-ethnic groups have rarely been developed, adopted, and tested. And furthermore, little is known about practical issues in adopting and using a technology-based intervention behavior program for multi-ethnic groups. Therefore, the purpose of this study is to share the lessons learned from the development of 3 technology-based behavior interventions adopted and tested for various multi-ethnic groups in the United States. So let me briefly explain the intervention components of the study, and the theoretical basis is based on Bandura's self-efficacy model. And the Kim components are one-to-one interaction between the participants and an interventionist. And it focuses on culturally matched interactive educational models, as well as the curation of web resources. And we use the moderated forums as well. And the key features are automatic translations of posts and comments of forums, and we use wearable devices for data handling, and we use multi-language support based on a user's choice. And finally, we are responsive for web applications for multi-platform support. Regarding multi-language support, Ruby on Rails is a web development framework for agile development, requiring fewer human resources. And it provides an I-18N API for internationalization, allowing content management and web development to operate independently. The workflow involves preparing each language version of the content and including a local parameter such as KO for Korean and EN for English. And the server then delivers the appropriate language version based on the local value. And this is the screenshots illustrating this process. And this is also actually the culturally focused educational models provided to the participants. And regarding multi-platform support, browsers send various platform information, such as phone, tablet PC, or desktop version PC. Our research team uses Bootstrap, an open source framework developed by Twitter. And this is an example for the multi-platform support. And regarding automatic translation, we use Amazon Translate API. When the original text is created, it is automatically sent to Amazon Translate service through API and saved to local database. And there has been issue raised with using Microsoft Word to create text. If we create text on Microsoft Word, huge styling texts are added to the copied text and resulting in incorrect translation. Furthermore, all the translated texts are not perfect, so that a moderator needs to review the translated text and update the translation as needed. And this is also a screenshot of automatic translation. And the left side is the original post in Korean, and the right side is the machine translated text in English. And we use Fitbit, which is more economical than Apple Watch or Galaxy Watch, to actually track the records of the participants. And Fitbit has also very good advantage in providing free API for accessing the data. And users also control the access of their own data on Fitbit.com through authorization process. And Google actually acquired Fitbit in 2021. So Fitbit accounts are handled uniformly through Google accounts. And this is actually the screenshots of Fitbit, individualized Fitbit records, and individualized participants can keep their tracks, as well as the interventionists. So finally, the lessons learned are three big parts, and the machine translations need a human intervention, and Fitbit is economical for researchers, and web app is economical owing to Bootstrap. So if you have any questions, please send email to the following address. So to conclude for these presentations, lessons learned from technology-based intervention have been discussed. And for future directions, we can augment it of interventions with AI or individualizations of interventions using machine learning algorithms. Thank you so much for your attention.
Thank you, Dr. Liu. And we have about 20 minutes for discussion, and we invited many distinguished panelists. And let's start. Who start the discussion session?
Thank you for good lecture. I have one question to Dr. Yongcheol Kim. In your study, AI-QCA showed non-inferiority to OCT and very practical and useful in real-world clinical situation. one result can be predicted by comparing manual QCA and AI-QCA. Is superior than manual QCA?
I think it's the if the comparison of the manual QCA and the automated QCA is, I think, is the result is the similar. But real practice is that I think there is no hospital to use the manual QCA when we decide to the PCI. So that is the advantage of AI QCA, because it's just after getting the angiography within the 2 or 3 seconds. So AI QCA give the detailed information of the QCA length or diameter. But my answer is that the result is similar, but we can't use the manual QCA in the patient with cardiogenic shock state.
I'm Youn from Seoul St. Mary's Hospital. It is a great honor and privilege for me to attend this wonderful session. First of all, I'd like to express my deep gratitude for the 6 speakers for their wonderful, well-organized, highly informative, and inspiring presentation. I have one simple question to Dr. Seulgi Ryu. Thank you for your great presentation. I'm wondering, your concept is very promising. It could be applied at various behavioral modification or intervention. But have you compared the original English version of behavioral intervention and the Korean or Spanish or other cultural dependent intervention for a behavioral modification?
Thank you so much, Doctor, for your great question. And actually, I'm a first-year PhD student, and I'm actually learning in the process. And I'm also working as a research interventionist for this project. And I'm comparing actually the English version of the 3 different ethnic groups. And actually, the multi-ethnic groups are Japanese, Chinese, and Koreans for this research project. And we have not actually compared the only not multi-ethnic groups, maybe culturally tailored versus non-culturally tailored. But I have experienced that by providing culturally tailored interventions for maybe, because I'm Korean, so I'm dealing with Korean participants, and they are very satisfied with what they've experienced throughout this intervention process. So I think for this now, I've been very actually satisfied with what I've done throughout this year. Yeah.
Thank you.
Let me ask a question to Dr. Lee, Kwan-Seung Lee. Thank you for the inspiring presentation. I found it interesting that you underlined the needs for ecosystem and commercialization. I totally agree with that. All the new technologies we presented today are linked with commercialization, but they are not free. Education used to be educator-oriented, but these kind of new technologies needs companies. And for me, the opportunities are usually came from specific manufacturers. So. Yeah, can you give us your insights into this issue?
Yes, I think Germany has probably done the most with regards to standardizing a national system of simulation training. There is the German Cardiac Society actually has set up 2 or 3 dedicated simulation sites, because to your point, it is almost impossible for small singular sites to be able to amass the type of simulators that you need at that scale and cost. So the German Cardiac Society basically assigns every year, if you are a trainee, you have to get 20 points. And you can get that 20 points by going to this national specific site. And there they have the full spectrum of different simulators. And they are very focused, and they have a professional crew of trainers who then conduct the simulation training almost on an every 2-week basis throughout the entire year. Because I think one of the problems is you cannot, most of us do not have the skill set to be able to successfully train people on the simulators. And so one of the issues that we've been faced with is the cost because of the economies of scale. We simply don't have widespread uptake that's large enough that helps us make the simulators cheaper. So we are caught in this current catch-22 situation where it's too expensive, we can't afford it. And so I think the beginning is really getting ourselves organized into national systems of training, so that we can all have access.
Thank you. We have a long way to go.
We have a very, very long way to go. But I think it brings us back to that moral question from the beginning. It is not correct to learn things that we can train on simulators. And I think we all know this in a clinical environment, because whenever my family member goes into the cath lab and I see a trainee there, I always ask my friends, please, can you do the case and not the trainee? And once you see that, what you've just done yourself there, we cannot be hypocrites, and it's possible to do. The flight simulation industry achieved this. We just have too much inertia, and we are too comfortable in our old ways.
I'd like to ask a question to Dr. Higami. I thought that your discussion around AI guiding catheter simulation was quite interesting, but the logical progression of that would be that you could theoretically use AI to design guide catheters for a particular case. So, for example, with ACHD cases where traditional guide catheters don't work very well, you could use 3D printing to print the specific guide catheter for the specific case. I mean, have you progressed to that level, or are you thinking of progressing to that level?
Yes, that's right. This simulation system will contribute to adult congenital heart disease, but the purchase size is very, very fewer than the adult PCI patients. But I want to improve this simulation system for adult congenital heart disease patients because the contribution is very big, I think. So I will improve that.
I think we have another question from the audience now. So over to you.
Thank you for organizing this wonderful session. And my question is addressing to Dr. Yongcheol Kim. So my first question is, in your study, is there any case in which you have to correct the vessel contour by manual? If yes, how you manage those cases? My second question is, there is several software is calculating QFR or FFR based using the AI. So, but the last trial showed that AI-based QFR calculation is inferior compared to the pressure wire-based traditional method. So, which method do you prefer, QFR, AI-based QFR, or wire-based FFR calculation in your practice? Thank you.
What I'm remembering is the first question is I think his operator never touched the outline that is in the AI-QCA during the PCI, is what I remember. And so is the other FFR is a computed is a FFR. Sometimes is we have to make an effort is to draw the right is the lumen line, but is during the AI-QCA PCI assisted PCI, I never ever used the make some draw to correct the lumen line. And the second thing is actually I'm interventional cardiologist, and already the published data show that Favor 3 Europe trial is the non-inferiority of the QFR compared with the wire-based FFR. And so I love the wire-based FFR.
So maybe a question for Dr. Bon-Kwon Koo, because I think you're looking bored there. I think you've convinced us that AI in coronary imaging is completely mainstream. My question to you, and I guess this is a concern that many of us have, is that any one of us can develop a risk stratification tool and put it on Google or produce a GitHub tool and people can use it. And yet, I couldn't go to my garage, produce a TAVR valve and get my friends to use it. It has to be regulated. It has to be subject of a trial. And yet many of this technology doesn't. I mean, how do you see regulation needing to be implemented going forwards?
Yes, I think that's a very, very, very important question. So I can show you beautiful images and models performing AUC 0.995 using overfitting. There are several technologies to do that. But as you mentioned, that the question is this real AI generally applicable to different ages, different sexes, different races? But we still have such a kind of a shortages in providing that kind of information. And I still say that this is AI-enabled QCPHA, but it's more like close to the automated analysis rather than true AI. So we actually practically didn't teach that much about the prognostic implication and treatment strategy selection, et cetera, so that we are already using that, but as you very properly pointed out, so we still need several barriers to go over to find a true AI-based treatment strategy that can be applied to a general population.
And I have one comment, and recently an interesting paper was published in the Nature, and they introduced the function of AI agent. And the AI agent is like a moderator, so it can control different AIs. For instance, if you develop a diagnosis, treatment, or prognosis prediction AI, and the AI agent can manipulate the different the AI softwares. It is, I think, it is the future of ours. And then regulation is a different story. So then many countries now thinking about utilization of AI and utilization of public data or private data. So maybe we need more time. Yeah. But however, not very far, I think. And another comment or question?
Let me ask a question to Dr. Higami. Interesting work. It looks like some of your work is based on simulation with conventional monitor, and some of your work was using VR head-mounted device. What is the virtue of using VR sets?
We are using virtual reality guided catheter simulation. I construct the polygon data from the cardiac CT, and I already made the real-size guiding catheter polygon, and I uploaded to the VR headset device. And then in the virtual space, I can move the guiding catheter polygon freely and fit to the real-size patients' aorta, including valsalva and coronary artery. And we can think in the virtual room how to engage to this guiding catheter to this coronary artery. And after that, the answer, I will find the answer because this guiding catheter from right radial approach maybe works like this position. So the virtual reality is very educational, but takes time. Because constructing from the cardiac CT polygon data and uploading, and I put the headset, and it's so complicated. So I transfer to the artificial intelligence in the full auto guiding catheter simulation. And the guiding catheter simulation by AI is very useful in real-world clinical practice. But virtual reality simulation is very useful for education, I think.
So I think we've got a final question from Yoshi.
Yes,
and
yeah.
then-
Yeah, I have just one comment and maybe one question for the Professor Koo. The first comment is that I think the AI algorithm, the way it is developed is also improving. Like in the first generation of AI algorithms, such as the, for example, OFR software, which is detecting the TICFA based on OCT, but the ground truth was the human eye or the core lab assessment. But now newer report, like a group of the Mark Feldman reporting the AI algorithm based on OCT, but using the histology as ground truth. So maybe using the histology, you could really, AI could beyond the human eyes and maybe doing the very correct diagnosis beyond the human eyes. So I think that TICFA and I think Brandon Brack is an interesting topic for this AI. And I'm really impressed by this Emerald 1 and Emerald 2 done by the Professor Koo. And the CT can really predict some vulnerable plaque. But I think the natural way of thinking is that if you use this plaque vulnerability prediction, maybe you could improve the treatment, or maybe I think in one of your slides you suggested maybe they change the medication, etc. But the question is what is the positive predictive value of this AI-QCPHA? Because from the intravascular imaging, there is a VH, there was the near spectroscopy, but nothing is 100%, and even 50% is very difficult to achieve to future events. So with your algorithm, what would be the positive predictive value of the of your algorithm?
Yeah, so Yoshi, I think that's another very important question. So, but this case, actually positive predictive value is very high because we selected only the patient who have acute coronary syndrome, so it cannot be generalized. And having said that, I agree that we are using generally binary definition in terms of vulnerable plaque, such as a cap thickness and the lipid arc, but we all know that it's a kind of a continuous variable, and we teach the AI not mimicking our definition, but if you can send all the images to the AI and learn by themselves to predict the future, I think that they will say totally maybe the different thing. And one step forward may be that we need to be above the binary discrimination of the plaque and let all the possibilities in teaching the AI. And one element may be that the AI-QCPH, we are not using binary, so quantitative analysis, all the continuous variable, so that that kind of a changes may provide the level of confidence you may ask on top of the current human intelligence-based definition. But again, as Dr. Kim and Dr. Mamas already mentioned, that we still need more data to say that the real AI-based individual, tailored approach.
So with that, I'd like to thank all 6 speakers. I thought it was an absolutely superb session. I'd like to thank my co-chair and the panel members. I think we've really seen what the utility of AI is across a lot of different indications, but we've also heard from some of the speakers some of the limitations. So thank you to all of you.